Imagine for a moment that you were going in for a highly anticipated surgery.
Right, a really big deal.
Exactly. You're finally fixing this totally frustrating problem urinary leakage
Yeah.
that has, heavily impacted your quality of life.
Oh, absolutely. It takes a huge toll.
So you do the prep, you go into the anesthesia, and you wake up expecting to be completely cured. But instead, you find out that the plumbing hasn't just been fixed. It's been, shut off completely.
Which is just a terrifying thing to wake up to.
It really is. It's this
Hmm.
classic medical paradox. In the attempt to fix the leak, the surgical intervention accidentally created a dam.
Yeah, and it creates this incredibly distressing scenario for you as the patient. I mean, you go into the operating room expecting physical freedom, and you wake up unable to perform one of the most basic autonomic human functions.
The psychological whiplash is just intense.
Intense, yeah, it's traumatic.
Well, welcome to this custom deep dive, where we are looking specifically at this exact scenario for you today.
We really want to dig into the details on this one.
Yeah, we're exploring how surgeons manage this highly complex complication known as post-operative voiding dysfunction, or acute urinary retention, specifically following a mid-urethral sling surgery.
And the stack of sources we are synthesizing for you today is honestly so robust.
Very robust, yeah.
We are pulling from contemporary clinical trial data, official surgical guidelines published by the American Urological Association.
AUA, right?
Right, it's
Yeah.
AUA. And some really highly detailed retrospective studies from major urology departments, particularly looking at surgical escalations.
So our mission today is to kind of demystify the medical detective work happening behind the scenes here.
Yes, the step-by-step process.
Exactly. We want to understand the escalation protocol that surgeons use to get things flowing normally again, but without undoing the entire clinical benefit of the original surgery. Okay, let's unpack this.
Let's do it.
Before we're going to talk about how to fix the complication, we really need to look at the biomechanics of the original surgery, right? Why does it sometimes work a little too well?
Right. Well, the original procedure we are analyzing is the placement of a mid-urethral sling, or MUS,
And as you know, this is the gold standard surgical treatment for stress urinary incontinence.
which is incredibly common.
Right.
Yeah.
Affecting up to 1 in 3 women.
Exactly. When conservative management like, pelvic floor physical therapy, when that fails, surgeons turn to the sling. It's a remarkably ubiquitous procedure.
Over 3 million performed worldwide.
Over 3 million, yeah, to date.
So when you look at the mechanics of those 3 million procedures, the intervention relies on this very, very small piece of hardware.
Shockingly small.
Yeah, the surgeon just places a strip of polypropylene mesh, and it's only about 1 centimeter wide, woven to create these specific pore sizes directly underneath the middle portion of the urethra.
It is essentially reinforcing the natural pelvic ligaments that have weakened over time.
Due to things like childbirth or just aging.
Right. So normally when a patient strains or coughs or exercises...
The sudden pressure causes a leak.
Exactly. That sudden intra-abdominal pressure causes the urethra to shift, resulting in a leak. But this synthetic sling acts as a rigid backstop.
So the sudden downward pressure forces the urethra to compress against this new mesh, which seals off the tube and prevents the incontinence episode.
That's the goal, yes.
I always visualize this as like stringing up a tiny tension-free hammock underneath a flexible garden hose.
Oh, that's a great way to picture it.
Right. Because when there's sudden pressure from above, the hose gets temporarily squished against the hammock and the water stops. But the vulnerability in that system, though, is the tension.
The tension is everything.
If that hammock is secured just a millimeter too tight during the setup, or if the surrounding human tissue becomes highly edematous-like, if it swells up after the surgery, that hose is compressed continuously.
The water can't flow even when the pressure is totally released.
And that blocked hose is the exact mechanism behind post-operative voiding dysfunction, or POVD.
Right. And in the acute phase, we often refer to it as post-operative urinary retention, or POR. Yeah. The detrusor muscle of the bladder is contracting, desperately trying to push fluid out. But the physical obstruction at the urethra prevents emptying.
And looking through the literature provided in our sources, the reported rates for this complication are incredibly inconsistent.
Are all over the place.
Depending on the study, retention rates are documented anywhere from 2.5% all the way up to 36%.
Which is a massive gap.
Right. That massive variance suggests the medical community doesn't even have a universally standardized threshold for what constitutes clinical retention versus just normal post-operative sluggishness.
Well, that variance absolutely comes down to diagnostic criteria. Some studies define retention as needing a catheter for 24 hours, while others look at a full 7-day window.
Oh, I see.
But the actual immediate diagnostic tool used right there in the recovery room is brilliantly objective. It's known as the retrofill voiding trial.
The protocol for that trial is fascinating.
It's so cool. I mean, from a clinical perspective.
Yeah. So the patient's lying there in the recovery bay, and the surgical team uses a catheter to intentionally backfill the bladder with exactly 300 milliliters of sterile water.
Which is roughly the volume of a standard mug of coffee.
Okay, so then they remove the catheter, and the patient is instructed to use the restroom.
And to successfully pass this trial, the patient must void a minimum of 2/3 of that 300 milliliter volume.
Or they can pass by voiding at least 200 milliliters, right?
Right, provided that the volume they eliminated is greater than the post-void residual.
The fluid left behind.
Exactly, which is measured with a really quick, non-invasive ultrasound scanner.
But failing that test sets off this huge cascade of interventions.
The immediate protocol dictates that a Foley catheter and indwelling tube is placed right back into the bladder.
And the patient then goes home with a urine collection bag strapped to their leg.
And the clinical data highlights how devastating this specific outcome is for you as a patient. I mean, women consistently report in surveys that going home with a Foley catheter was the absolute worst aspect of their entire surgical experience.
I can completely understand why. It introduces severe embarrassment.
It necessitates additional urology visits.
And it serves as the leading vector for hospital-acquired urinary tract infections.
It essentially transforms a minimally invasive, same-day outpatient procedure into this highly uncomfortable, prolonged medical ordeal.
So the hamby is too tight, the patient is miserable, and the surgeon now has to initiate an escalation protocol.
Right, they have to do something.
The immediate first line of defense seems kind of counterintuitive,
Yeah.
but it heavily relies on time. Just expectant management.
Because tissues subjected to surgical trauma naturally undergo a profound inflammatory response.
It swell up.
Exactly. The localized swelling and edema can easily create enough transient bulk to compress the urethra against the newly placed mesh. So by simply waiting 1 to 2 days, the inflammatory markers decrease.
The swelling subsides.
Right, and the retention often resolves completely without any further surgical manipulation.
But during that waiting period, leaving an indwelling Foley catheter isn't the only option, right?
No, not at all.
The sources indicate that many clinics transition patients to clean intermittent catheterization, or CIC.
Which is a huge improvement for quality of life.
Yeah, instead of a permanent tube, the patient is taught to use a small, disposable catheter to manually empty their bladder every few hours.
And this prevents the detrusor muscle of the bladder from becoming overstretched, which is critical, because overstretching can cause permanent damage to its contractility.
And while waiting for that swelling to decrease, surgeons also utilize pharmacological interventions.
They do.
The primary drug mentioned across these clinical trials is tamsulosin.
Yes.
But wait a second, let's look closer at that medication choice. Tamsulosin is widely known by the brand name Flomax.
Right.
It is explicitly marketed and prescribed as a prostate drug for men suffering from benign prostatic hyperplasia.
An enlarged prostate, yeah.
So why are urologists prescribing a medication designed for male prostates to women recovering from female pelvic reconstructive surgery?
Well, what's fascinating here is how the underlying mechanism of action supersedes the commercial marketing of the drug.
Okay.
Tamsulosin is an alpha-adrenergic receptor blocker. Its primary biological function is to force smooth muscle tissue to relax.
And men have a high concentration of that smooth muscle in the prostate capsule.
They do. But, human anatomy is remarkably conserved. Women possess those exact same alpha-adrenergic receptors densely packed within the smooth muscle of the bladder neck and the proximal urethra.
Oh, wow. I had no idea.
Yeah. So by administering this highly accessible, $2 medication, the goal is to induce pharmacological relaxation of the bladder neck.
It essentially widens the funnel just enough to let the urine slip past the edematous tissue in the surgical sling.
Exactly.
Well, the theory is elegant, I'll give it that.
Mm-hmm.
But the clinical trial data on tamsulosin for this specific application is surprisingly contradictory.
It is very mixed.
A highly cited randomized controlled trial by Chapman and colleagues demonstrated phenomenal results using a 10-day regimen.
The 10-day protocol, right?
Patients took tamsulosin for 3 days prior to surgery and 7 days post-op. And in that cohort, Post-operative urinary retention rates plummeted by 65%.
That is massive.
Right. It dropped from a 25.8% retention rate in the control group down to just 8.8%.
A 65% relative risk reduction is a huge statistical win.
Yeah.
But the logistical barrier, however, is patient compliance.
Ah, of course.
A 10-day medication protocol leading up to a rapid same-day surgery introduces a lot of friction. Surgeons and patients prefer streamlined care pathways.
Nobody wants a complicated prep for an outpatient procedure.
Exactly. And that desire for efficiency led a different team of researchers to design a new randomized controlled trial with a much more practical question. Like, could a single preoperative dose of tamsulosin achieve the same smooth muscle relaxation?
The methodology for that newer trial involved giving the patient just one pill in the pre-op holding area, literally a few hours before the incision.
Right, because pharmacokinetically, tamsulosin given to a fasting surgical patient reaches its peak blood concentration in about 4 to 5 hours.
That makes perfect sense.
Oh.
So the drug hits its maximum systemic levels right as the patient is waking up and attempting their avoiding trial.
The clinical setup was absolutely perfect, yet the results were entirely negative.
Wait, really?
Yeah, the single-dose regimen had absolutely zero clinical effect on preventing urinary retention. The statistical rates of failure between the tamsulosin group and the placebo group were, like, identical.
Zero effect. Wow.
Yeah.
When you analyze why a 10-day regimen succeeds while a single dose fails, it comes down to receptor biology, doesn't it?
It absolutely does.
Smooth muscle relaxation in the bladder neck isn't some simple light switch that flips the moment the drug enters the bloodstream.
No, it takes time. Achieving meaningful clinical relaxation likely requires a steady-state blockade of those alpha-1 receptors.
Built up over several days of continuous dosing.
Right, rather than just relying on a single transient pharmacokinetic peak.
So the single-dose failure emphasizes a hard truth in postoperative management. Shortcuts rarely work.
They rarely do.
And if the expectant management fails, like if the swelling has subsided, days have passed, and the pharmacological interventions aren't working, the patient remains catheter dependent.
Which is an awful place to be.
Right. And at this critical juncture, the surgeon faces a ticking clock.
A very literal biological clock.
And that ticking clock is dictated by the cellular integration of the mesh itself.
Because that 1 centimeter polypropylene sling isn't just sitting in the tissue, it is actively being incorporated.
Right. The pores in the synthetic weave are specifically sized to allow the patient's own fibroblasts to enter and begin laying down collagen.
The tissue literally grows directly through the mesh, anchoring it permanently, almost like rebar set in concrete.
And that fibrotic ingrowth and collagen cross-linking process takes approximately 3 to 4 weeks to fully stabilize.
So if a surgeon waits beyond that window to address an overly tight sling, the mesh becomes permanently locked in that obstructive position.
They have to intervene before the biological concrete cures.
Exactly.
And the sources detail a specific office-based procedure to accomplish this, known as transurethral sling loosening, which was pioneered by Coram and his team.
It's a clever intervention.
Yeah, utilizing local anesthesia, the surgeon inserts a smooth metal dilator, called the urethral sound, directly into the urethra.
And then they apply firm, downward mechanical traction.
The goal is to physically stretch or disrupt the tension-free vaginal tape before the tissue integration is complete.
Right. It relies entirely on the malleability of the early healing phase.
Think of it like buying a new pair of stiff leather boots that are a half size too small.
Oh, good analogy.
If you manually stretch them on a shoe tree on day 1, the fibers yield and the fit becomes perfect.
But if you stubbornly wait a month until the leather has hardened and formed tightly to your foot, causing severe blisters,
the mechanical damage is already done, and simply pulling on them won't fix the underlying structure.
Exactly. And the AUA guidelines are incredibly explicit about this timeline. Early relief of the obstruction is paramount.
They say intervening under 8 weeks is necessary, right?
Yes, but acting within the first 14 days is clinically ideal. Data shows that early mobilization is strongly associated with a dramatically lower incidence of lifelong, permanent voiding dysfunction.
Here's where it gets really interesting, though. You apply the downward traction with the urethral sound, but the tissue is already scarred, or the tension is simply too great. The manual stretching fails.
Which happens.
And now the patient is facing chronic urinary retention.
This represents the most dreaded inflection point in the treatment algorithm.
The point of no return for conservative methods.
Right. The conservative measures are totally exhausted, and the surgeon must escalate to a formal return to the operating room.
And they don't just have one standard revision surgery to offer, do they?
No, they face a menu of highly aggressive surgical options. And every single choice carries a heavy physiological trade-off for the patient.
So looking at the data on surgical escalation, the two primary interventions are partial excision and urethrolysis. Let's start with the less invasive option.
Partial excision.
Right, in a partial excision, the surgeon makes a vaginal incision to access the site of the original surgery, isolates the tight polypropylene mesh, and sharply divides it.
They cut a small segment out at the midline, instantly releasing the tension on the urethra.
And the alternative, urethrolysis, is a vastly more aggressive anatomical undertaking.
Much more aggressive. I mean, the term lytisis literally means to break down or destroy.
So in this procedure, the surgeon must perform a comprehensive, sharp dissection of the entire urethra, freeing it completely from all surrounding scar tissue, fibrotic bands, and mesh remnants.
You are fundamentally remobilizing the entire urethral structure.
If you are managing this complication, you might wonder why a surgeon wouldn't just default to the simple excision every time, right?
It seems like the obvious choice.
But the sources included a highly revealing retrospective study from the Department of Urology at NYU, analyzing a contemporary cohort of 110 patients who required these exact OR revisions.
And the data paints a very complex picture of risk versus reward.
The NYU study found that partial excision is remarkably effective, boasting an 86.6% success rate in resolving the urinary obstruction.
Which is excellent. And it is also significantly less morbid, meaning the surgical trauma and recovery burden on the patient are minimized.
But urethrolysis, surprisingly, demonstrated a slightly lower success rate, just 75%.
Which seems completely counterintuitive.
Right. The lower success rate for the more aggressive surgery seems backwards until you look at patient selection.
Exactly. Surgeons are actively reserving urethrolysis for their absolute most complicated refractory cases.
They're selecting patients whose clinical presentation has deteriorated way beyond simple retention.
These are often patients whose primary post-operative complaint has evolved into severe intractable pelvic pain, suggesting like extensive nerve entrapment or severe scarring.
Wow.
Yeah. Urethrolysis is also utilized as a salvage operation for patients who have already undergone a partial excision that ultimately failed to relieve the blockage.
So they execute the excision, or the urethrolysis, the anatomical tension is finally relieved, and the patient can void normally again.
The plumbing is unblocked.
But the data reveals a secondary wave of complications.
Yes. If we connect this to the bigger picture, the cruel irony of incontinence revision surgery becomes starkly apparent. You have to remember the initial catalyst for this entire surgical journey.
Right, the patient originally went under anesthesia to stop their stress urinary incontinence. They wanted to cure the leaking.
Exactly. But when the surgeon surgically cuts or destroys the mesh sling to cure the new urinary retention, they are simultaneously destroying the anatomical backstop that was curing the incontinence.
Oh.
Yeah. The NYU data quantified this setback. Stress urinary incontinence, documented as de novo or recurrent SUI, returned in approximately 21 to 25% of patients across both revision procedures.
That is heartbreaking. The patient undergoes a second, highly invasive surgery only to find themselves right back at their initial baseline, leaking urine again.
You fix the blocked hose, but in doing so, you restart the original leak.
And the physiological toll goes even further, particularly with the more aggressive intervention.
Much further. Because urethrolysis demands such extensive, sharp dissection of the delicate periurethral tissues, it carries a severe risk of neurological and muscular disruption.
It frequently triggers a completely new pathology, overactive bladder, or OAB.
Which is brutal.
So a patient transitions from absolute urinary retention, unable to pass a drop of fluid, to suddenly experiencing severe, uncontrollable urges to void constantly.
Because the neuroelectrical pathways that govern the detrusor muscle are highly sensitive to surgical trauma.
The NYU study documented that new-onset OAB symptoms developed in a staggering 21.4% of the patients who underwent urethrolysis.
Over 1 in 5.
And when you compare that to the partial excision group, the OAB rate was only 7.3%.
So the deeper the surgeon has to dissect to free the urethra, the drastically higher the likelihood of triggering detrusor instability.
So what does this all mean? We have tracked a remarkably delicate medical escalation today.
A really difficult journey.
Right. If you find yourself facing post-operative voiding dysfunction, the protocol begins with extreme patience and a heavily debated $2 alpha blocker pill.
Hoping the steady-state blockade kicks in.
And if pharmacological steady states fail, The management shifts to manual physical stretching in the office. You're constantly racing against the biological ticking clock of collagen cross-linking and mesh integration.
Right, before the concrete sets.
And if that window closes, the patient is forced to navigate complex, morbid revision surgeries, where successfully unblocking the anatomical hose runs a 25% risk of restarting the original leak or a 20% risk of triggering a new overactive bladder.
It reinforces the reality that surgical intervention is rarely about achieving a flawless cure. I mean, it is an exercise in expertly managing shifting risks, physiological trade-offs, and establishing highly individualized clinical goals alongside the patient.
Absolutely.
However, diving into the nuances of these sources revealed one final, really radical approach to this complication.
Yes. Looking at how devastating a failed voiding trial is for the patient's psychology, some urology departments are entirely rethinking their preoperative pathways.
It's pretty innovative.
They're actively teaching patients the mechanics of clean, intermittent self-catheterization, like how to properly insert a urinary catheter themselves, days or even weeks before they ever undergo the sling surgery.
It is a brilliant strategy for mitigating anxiety. I mean, by normalizing the catheterization process before the trauma of surgery, they completely remove the shock, the fear, and the helpless loss of autonomy if the patient wakes up in acute retention.
But the clinical theory extends even beyond basic procedural education.
Right, it pushes into the realm of functional prevention.
Exactly. If urologists can utilize urodynamic testing to predict which patients are at a higher statistical risk of failing a voiding trial, perhaps those who already exhibit a slightly diminished urinary flow rate, they could deploy targeted interventions beforehand.
The concept is utilizing specialized pelvic floor physiotherapy and biofeedback, not just as a reactionary postoperative treatment, but as a preoperative training regimen.
They could actively prehabilitate the bladder.
Prehabilitate, I love that term.
Right. By teaching the pelvic floor musculature how to efficiently and completely relax before the polypropylene mesh is ever implanted, surgeons might be able to ensure the anatomical hammock never chokes the hose in the first place.
Potentially eliminating this dreaded complication entirely. Prehabilitation represents a fascinating frontier in functional urology. It shifts the focus from surgical salvage back to physiological optimization.
Using neuromuscular training to prevent a surgical complication before the anesthesia even takes effect is definitely a powerful thought for you to linger on.
Something to really think about before going under the knife.
Absolutely. Well, thank you for diving into the complex biomechanics and surgical data with us today, and thank you to the listener for joining us on this custom deep dive.
It's been a great discussion.
We hope this has thoroughly demystified the intricate world of pelvic reconstructive surgery and complication management. We'll see you next time.